All right, hello everyone, and welcome to our HIMSS event on Clinician Mental Health Crisis. Today is August 25th, and I'm coming to you from Seattle, Washington. My name is Joanna Valderrama, and I'm the program chair for our Washington chapter. So on behalf of our board, we're really excited to present this group of panelists to you because they have a lot of great information about mental health and impact on our clinicians, especially in the last couple of years during the pandemic. So before I go on, this particular event will be recorded, so you'll be able to access it through our YouTube channel, and I'll put that link later on in our chat box. If you're just joining us, please remember to mute yourselves. We do have a Q&A section at the end, so feel free as you're listening to us and watching the slides, post those questions in the chat. Let's see. So our agenda today is I'll give you a quick introduction about our chapter, and hopefully if you're interested in the event and all the other events that we've hosted, you'll also be interested in joining our chapter. I'd like to go a little bit and talk about our panelists and their background in terms of their career and their experience around mental health. Then we'll get into the juicy stuff around our topic of the evening. We'll have Q&A, and then I'll give you a little bit of our chapter updates in terms of our upcoming events that you can join us at and how to reach us. So HIMSS, if you're not familiar and you're just joining us for the first time, it's the Healthcare Information and Management Systems Society. We are a nonprofit organization where we really help to seek to be a leader in terms of providing a resource for others who are really passionate about healthcare IT. And I put a little link there at the bottom of the slide, but I'll also put that in our chat so you'll know how to find more information about us. Our vision in terms at the national level is we're here to realize the full potential of every human everywhere, but really it's also to reform the global health ecosystem through the power of information and technology. In terms of what HIMSS does specifically, as I mentioned, it is a global nonprofit organization. And so they do offer a variety of different solutions, initiatives, opportunities, and public policy and advocacy assistance. So there's tons of ways that you can interact, communicate, and engage with HIMSS, whether it's at the national level or if it's at your local city, chapter, or state level. So this is just a screenshot of some of the opportunities that are out there, in addition to volunteering and becoming a sponsor as well. As I mentioned, we are a nonprofit, so we would like to take a moment to thank our elite sponsors, SailPoint and Fujitsu. And so let's get into the fun pieces. We're going to meet our panelists now. I'm going to go from the top left and I guess clockwise. So we'll start with Dr. Kira Mosef. She's actually here in Washington. She's a partner at the Snohomish Psychology Associates. She is OCOLI as well for the Behavioral Health Strike Team in the Washington State Department of Health and Associate Teaching Professor for Seattle U. She has other credentials and other titles, but I couldn't fit them all in here. So I picked the top three that I thought were most representative of this particular event's topic. Then from Canada, we have Jillian Strudwick, who has a background in nursing. She's a chief clinical informatics officer and scientist, so very cool positions and titles for the Centers for Addiction and Mental Health in Ontario, if I'm correct, right? Then we have Dr. Tanya Tajirian. She is a CMIO and chief of the Hospital Medicine Division at the Center for Addiction and Mental Health as well. Oh, you know what? How did I skip that? I'm so sorry. I thought I was going to go clockwise. Then we have Dr. Romina Elias. She is a healthcare CNIO at Bell Technologies in their Healthcare Life Sciences Division. And then we have Yael Swerdlow. She is the CEO, founder of Maestro Games. She's also has a long list of different associations and involvements that she's part of, and I could not fit them all in there as well. So I'm really excited to have all of them. I'm hoping to also be able to kind of provide a little bit more about their background as as we go on through the event, because I did not do them justice in this minute. All right, so I'm gonna ask a poll question first, and let me launch that in a second. But the question is, because we're really interested in our attendees, we're really interested in terms of workplace stressors, what has contributed to changes in your mental health in the past few years? So I'm going to launch that poll in a second. So that should come up. And let me know if you don't see it. Again, a few seconds. I'll wait for 2 more folks who haven't answered, and it might just be that they don't have access to the poll through their device. We'll give it a couple more seconds. And so far, it looks like understaffing and heavy workload is winning. I'm sure there's 1,000 more things, but of course, you know, they won't fit here. I'm going to end the poll and then share the results with you all. And I don't know what you guys see on your end, but I think it's the the results, yes? So yeah. Understaffing is a big one. Thank you. Understaffing looks like it's a big one. Heavy workload, poor morale, and then others, and then type them in the chat. So let's see what we have in the chat. Diana says, working remotely, lack of interpersonal interactions. That's a good one. I didn't think to put that in there, but thank you for adding that. Feel free to continue adding more into the chat as well. Okay, so let's see. So let's talk a little bit about the background, and this is where I'm hoping our panelists can kind of give their insights and perspectives based on their various backgrounds around clinician mental health, the impact, especially during the pandemic. So we'll start with this slide, and I think that was Dr. Kira's slide.
Yeah, thanks. Hi, everyone. I like to sort of provide this as a beginning place because it gives a lot of good framework for how things have built up over time. So this is a graph that was originally designed by SAMHSS several years ago, probably about 5 years ago now. And it was based on aggregated data from large-scale disasters all over the world for the last couple decades. So things like Hurricane Katrina and 9/11, the earthquake in Haiti, tsunami in Southeast Asia, et cetera. All large-scale disasters, it turns out, regardless of whatever type they are, go through these fairly well understood phases. So the impact phase is usually about 0 to 48 hours. The heroic and the honeymoon phase start around 1 month post-impact. So for COVID, with the healthcare community, impact phase was March, in Washington state, at least it was in March of 2020. It happened at slightly different times throughout the country and in other countries as well over the course of 2020. But heroic and honeymoon were characterized in 2020 by the Tiger King and hoarding toilet paper pretty much everywhere. That seemed to be a universal. So that was about that time frame. It feels like 5 years ago in a lot of ways. But we tend to proceed then from the honeymoon phase into what's called disillusionment. And the disillusionment phase is when the mental health impacts really start to show up. It takes the human body and brain about 6 to 9 months post-impact from a disaster, especially of this magnitude and complexity, for the reality to really sink in. So the disillusionment phase is when the limits of assistance become clear, the money starts to run out. It really becomes more of a sense of desperation about, man, we're not going to just zip our way out of this thing. It's a slow path to reconstruction. In the case of a disaster like an earthquake, reconstruction is a literal event. In the case of the pandemic, it can be conceptual, it can be social. There can be all kinds of ways that that plays out. So that's the general concept of the phases of disaster. Joanna, can you skip to the next slide, please? So this is a chart that my Department of Health team for Washington State updated based on COVID specifically, taking the disaster pattern and cycle, typical cycle in mind. And we added what we refer to as a secondary and then a tertiary or a third impact from the Delta variant and from Omicron. So what we are in right now is something that the disaster literature talks about in quite a bit of detail, which is called a disaster cascade. And disaster cascades are defined as more than one large scale impact within the same window of time that it would take us to recover from the first impact. Keeping in mind too, that regionally, locally, there might be 4 or 5. There have been floods, there have been fires, there have been other large scale impacts in various communities. So it might not be just 3. What I can tell you with some certainty is that there have been just 3 from COVID alone in the last 2.5 years. And that is a lot for us to try and recover from collectively. The cascade effect increases symptoms in behavioral health. And for many people, especially people who are operating as healthcare workers often were and are in high stress situations with shorter or fewer resources maybe than other types of groups, it tends to enhance stress and result in a variety of other symptoms that are exacerbated by the specific conditions. So where we are now on this chart is in a huge variation in terms of our recovery. A lot of people are doing okay. They're kind of back to baseline. Some people are starting to feel better and some people are really still struggling. So there's not a right or a wrong path, but please keep in mind that the behavioral health experience for where someone is right now in terms of a disaster cascade from this context really can vary dramatically based on their personal and community experience. We define 3 groups of stressors, right? We have systemic stressors, which are things that people come into a disaster with. That could be something like racism or discrimination or marginalization, fewer access to resources. And then we have what we call primary stressors from the disaster, which are immediate threat or loss. Were you hospitalized? Did you lose a loved one? Did you lose your home, et cetera? And then we have secondary stressors, and those are financial and educational, maybe social. So wherever you are personally, as a provider or as a clinician, professional, or just a human being, is going to vary based on your exposure to those different stressors over the last couple of years. And then the last slide here that I will wrap up with in terms of context is that I just want to emphasize that the disaster literature is clear that even in a disaster cascade like the one we're in now, the population level outcome on a 5-year type of a scale, like way down the road here, is resilience. That is the most common outcome down the road. About 15 to 20% of folks are going to develop symptom acuity, which is not enough to meet the clinical threshold for a diagnosis of a new disorder. But it's going to be an increase in symptoms, right? Depression or anxiety symptoms, but not diagnostic. I'm going to estimate about 10% of folks are going to end up with a new diagnosis or a condition. Sometimes when you ask people like, what does recovery from large scale disasters look like? A lot of people think it might be PTSD, but in fact, resilience is the most common outcome by far. And then in terms of diagnosis, it would be an anxiety disorder, major depressive disorder, and then PTSD would be third on the list of likely culprits. The reason why I'm overestimating this chunk of the pie to 10% is because youth across the United States have experienced a disproportionately negative outcome. And they are struggling significantly more than adults are right now. And then the tiniest slice of the pie is something that we refer to as chronic dysfunction. And that is behavioral health impacts that are so significant that they really impede an individual from functioning effectively at work or in a home environment. So this is the general landscape for what we're looking at in terms of outcome, but none of this is set in stone. And part of the reason why it's so important to talk about and directly address things like burnout and compassion fatigue and moral injury right now is that we have the opportunity to pull more of us along on the resilience pathway and resilience outcome rather than some of these others. So I just like to give that large scale disaster context as we get started in the conversation.
Love that. You gave us hope at the beginning, which is great. Awesome. Any questions, again, please put those in the chat. And I will go to the next slide.
So I think this is where I'm to jump in, and I'll shift our focus a little bit to something that we've been hearing about a lot, perhaps something that you're experiencing yourself. as well as something that we had talked about before the pandemic, but we're hearing a lot more in the I was going to say the last few months, but this is, I don't know about yourself, but I've had this sort of weird time sense of it's been a long time, but it's been a short time. And so the definition, there are a few definitions of burnout, but often they come back to this one, which is the one that is used in the Maslow burnout inventory, and that is burnout is an occupational hazard caused by cumulative workplace stress that was recognized as a substantial problem in healthcare prior to the COVID-19 pandemic. And it consists of three things. So one is emotional exhaustion. Two is depersonalization, and the third one is the diminished sense of professional achievement. And this is what the Maslow burnout inventory actually measures, if you've heard of that, or the MBI. And so some of you may have participated in surveys yourself or seen rates of burnout or percentages of burnout, and it likely used a measure that was based on this definition. And so prior to the pandemic in the literature, the rates, I'm making like a very broad statement here, but we're in amongst the 30%-ish range. And there was a study that was published during the pandemic about a year in, a Canadian study that demonstrated that amongst nurses alone, rates are around 60% in this particular hospital setting. Now, this obviously isn't everyone's experience. It's going to vary significantly, and we don't always measure it in our settings. But I think what we can agree upon is that there has been quite a big increase in burnout for a lot of reasons. So we'll go to the next slide here, which brings up a topic that we were talking so much about, particularly in the HIMSS world. And this was, how do computers, how does the health record system, how does all of this contribute to burnout? And so that was a hot topic. And then all of a sudden the pandemic hit and we didn't hear as much about it, but we're starting to see it, at least in Canada, we're seeing it emerge a little bit more. But it's recognizing that the contributors to burnout are workplace risk-place factors, which are things related to workload, role, and processes. And one of those many processes is documentation and using the health record. And so I wanted to just put it into context that, of course, we're talking about this conversation more broadly. And we can go to the next slide here, which is, I think a lot of us recognize that the contributors to burnout were magnified during the pandemic. So things like workload, hours and shifts, some of the role characteristics and scopes in which we were practicing, presenteeism. So you could go on and on with some of these issues, but they're both a cause and a consequence, and you get this vicious sort of negative cycle. And so in our province in Ontario, I was fortunate to sit on our science table this is part of creating a policy brief for the government saying, well, there's a few things we ought to do, but a lot of it has to do with the work environment and targeting interventions for burnout really at the organizational and system level. And I know Dr. Tajurian will be talking a bit about that later. So I think this is the last slide for me before I leave it off, but essentially that battery does not look like that in many places and in many folks right now. We tend to focus a lot of our interventions in this space at the individual level, which show often good impact at a short term, but in the long term, we have to have that coupled with organizational and system level interventions to be able to get back where clinicians and we are feeling like we're fully recharged. And so I will pass it on to the next speaker.
I am trying to get out of the sun for a second here. My apologies. Can you all hear me? Okay. So I wanted to address moral injury as a separate diagnosis from PTSD. And one of the things that has been noted with the burnout factor, and especially with the pandemic, is the level of moral injury that has been suffered by healthcare providers when they have to make decisions that go against their personally held beliefs, their professionally held beliefs. Deciding who gets to be put on a ventilator, the level of the lack of the protection equipment that you are not able to have in some of the hospitals. What was going on with the government in terms of denying the impact and the danger of COVID, just all of these things that impacted healthcare providers on a daily basis, trying to do their job and save lives, definitely caused the level of moral injury that is, I believe, unprecedented in the healthcare space, due to just the sheer number of decisions that had to be made in the moment. In my background as a photojournalist, one of the things is that moral injury is actually a prerequisite of the job, because you're required to stand by and hopefully bear witness to the tragedies unfolding in front of you, but you're not supposed to put your cameras down and get involved unless it's a life-saving thing that you're doing. And even then, sometimes folks don't. To illustrate what moral injury would be in that situation, there's a very well-known story during one of the famines in South Sudan, where a photographer had photographed a toddler who was clearly malnourished and dying of hunger, crawling after a man who had grabbed his bag of food. And the photographer was very clearly right there. It was shot wide, because in the image you have the toddler crying and crawling, and you see the man's leg with the bag of food. And so the question, the outrage against the photographer was, why didn't he stop the man from stealing this child's food? The photograph itself ran double truck, which back in the day when publications happened were both pages of the magazine. And a tremendous amount of money and support was raised by that photograph for the relief organizations that were sending, relief and food and everything to Southern Sudan. So the moral injury and the question is, well, if he stood by, then he let the toddler die, but at the same time, a tremendous amount of good was done by him standing by and taking that photograph. So that's a bit of what the dilemma is in moral injury. I'm in LA, and during the pandemic, and I live kitty corner to a fire station, and during the pandemic, I was used to the paramedics going out constantly, every 2 seconds. And then when the hospitals became so overrun that there was literally no room and no beds, it was just eerily quiet, because the paramedics were told that you can't bring a person to the hospital if it was going to save their life. For a heart attack, a shooting, or a car accident, you had to literally just let them die. And if you can imagine the moral injury that happened to the paramedics, who obviously go into that field for specific reasons to help people and to rescue people. So that's a little bit of the indication of why we're addressing moral injury here as part of the horrific byproduct of the burnout of the pandemic. So if there are any questions on that, or anyone wants to add anything to that?
Any questions from my attendees? I myself, this is the first time I'm hearing about moral injury. So I think this is great to present. I'm not sure that a lot of folks know about it unless they're working in in some type of mental health related field.
Yeah, it's not spoken about very much, unfortunately, and it's just starting to be spoken about and addressed specifically in the healthcare space. And the reason, again, that we're distinguishing it from PTSD is because PTSD is what happens to you, or something, an event. You were almost killed by something, or you were assaulted, or or you had to do something physically. Moral injury is the result of the PTSD. It's a separate thing. Moral injury is most defined as a wound to the soul. And so because you were forced to do something that went against your cherished beliefs, you feel the shame and you feel the despair and you feel like you're not deserving, for example, of beauty or joy, or you're not deserving of love, you're not deserving of community. So a lot of the manifestations of moral injury are folks will isolate. They will not be able to. They will try to numb out by trying not to feel the shame and the guilt from the moral injury. So at the same time, they're not going to be able to feel the joy or beauty. They'll literally just try and wall themselves off from all of their emotions. And it's really, really difficult to bring to feel beauty and joy and feel creative and play and all the other wonderful things that humans do when you feel like your moral code has been violated, if that makes sense.
So I think it's such a relevant topic as well. And for those who had gone through COVID and worked on the floor, so before I moved to this side of the technology, I was a senior nursing director for OB.
Oh, wow.
And at the beginning of the pandemic, we didn't have any protocols in place. And we were, much like everybody else, we're trying to figure out what to do for our pregnant patients who are now sick with COVID, who are going to deliver. So this is back then when we were restricting visitation. So I remember our first ever patient who was delivering, had to deliver by a C-section. She was sick with COVID and she was symptomatic. So we've had some OB patients who were sick with COVID but were asymptomatic. But our first one was particularly sick, and she was full term, needed to have her C-section. And she had to deliver the baby without her husband, without her family. And this is her first baby. So, and if you could imagine her in her room and everybody, all of her nurses, her care providers, all gowned up like aliens, essentially, with masks, hats, PPE covered. Talk about a very personal event in your life, and having to be severely isolated. So much so that your caregivers are also isolating from you because of this disease. So she had to deliver by herself without her family members there, and the care providers that were supposed to be caring for her were also in as much isolation as possible. So a lot of the nurses, and I know we've talked about this in our own circles, a lot of the nurses had what we were calling PTSD from them, but it's really moral injury.
Absolutely.
Right? Sharing that, unable to allow the family to bring a child in the world together, and having to be so isolated. That's and again, that's a very small example, but I know a lot of the folks on the call have their own examples of that type of moral injury as well. So absolutely very relevant in the discussion today.
I think one of the hallmarks of the Lorena Breen Healthcare Protection Act is that it acknowledged so much of the wound to the soul that drove her unfortunate suicide. There's in law enforcement and in military and in education and all the first responder verticals, careers, there is just an overwhelming amount of moral injury that's just swept under the rug because no one wants to talk about how do you bring back somebody from that level of a wound to their sacred beliefs. Because that requires systemic change.
Well, I just wanted to add one of the things that we were seeing here in Washington in conversations with hospitalists and ICU and ER folks, ED, was the degree to which they were exposed to death and dying without support. And whether that's colleagues getting sick, whether that's being the only person with access or exposure to a particular patient during their last hours or days, that's the kind of thing that certainly has a lasting effect. And I would absolutely categorize it in this same vein of one of the biggest impacts on coping and just health in general for those folks in that population. The inability to process death, inability to process grief and loss in a way that felt meaningful, in a way that was felt valid. It felt like there was always something missing or a process that wasn't done, and having to live with that, having to sit with that and carry it with them.
And Kira, I love that. I'm a frontline hospitalist and I've been on the COVID units for so long. I think the impact of what we have gone through has not yet sank in. Again, I remember very distinctively the first time I saw that chart of the first wave and how do we recover. And I remember there was a line, second or third wave. We couldn't even imagine that we're going to continue with the uncertainty for that long. And there's a lot of trauma that has been unprocessed, and moral injury, 100%. The other part that we're not talking about, at the beginning when we didn't have vaccine and there's all the fears and we didn't know enough about the virus, there was a lot of impact on the families of the healthcare workers. Yeah. Myself, I was separated from my daughter for 4 months just because we're frontline with schools. There's a lot of trauma that I don't think it's been processed yet because we're still going through. And even though there's an exodus of healthcare workers, physicians, nurses, I get it. But I think the impact is just going to get worse if we don't really look at things with a different eye and really work collaboratively on changing the systems.
100%. And that's the other part of it. PTSD and moral injury don't just affect the person, they affect their entire community, starting with their family, the immediate family. And, if you can, like your spouse or your children are outraged of the way that you have to risk yourself and sleep in, in a tent in your backyard or something like that. So it becomes an epidemic that is under the rug because people don't want to address it because they're so busy trying to maintain right now. And you're right, I don't think we've even seen the tip of this yet. And I think it's gonna, but the other part of it is that we're not taught how to deal with it. No one is ever taught how to deal with an affront to their beliefs in a constructive, healthy way. And that's also part of the issue, frankly. We're not ever taught how to, and it goes way beyond self-care or any of the pop psychology things. It goes to being able to create, as we pointed out, the resilience. We're the least resilient society in history because we don't have the tools. We haven't been taught the tools to care for ourselves. And that's also part of the problem.
Conversation. This is definitely a topic that I'm sure we could have one specific event on. But thank you for bringing this one up. So now we're going to kind of go into the findings. We gave you a little background, kind of the lay of the land of what's happening. And then now we're going to go into the findings and the data.
Oh, so I think this is my slide here as well. So one of the, I think what was mentioned before is burnout has existed way before COVID ever hit. And the shortage of healthcare workers have existed even before the pandemic. And this is actually the National Academies of Medicine had sent out this survey in 2019, and it found that 54% of nurses and physicians are suffering from burnout. 60% of medical students and residents are also suffering from burnout. And if you look at that, overall healthcare workers, 50% are suffering from anxiety, depression, or increased PTSD. And that, again, that's 2019 survey. So that, and I know a lot more surveys are coming out recently as well, and I see those numbers kind of increasing. I've seen 2.7 healthcare workers have resigned, and it does seem like a low number from what we are seeing. But that's an overall healthcare workers combined. And 1 of 3 nurses by a recent survey is thinking of leaving the profession. So that's 33% of our nurses who are thinking of leaving the profession, and I know we're seeing a lot more turnover in each of the organizations and facilities, and what we've seen is kind of a turnover or nurses leaving the bedside as a permanent staff and actually going into a travel position to afford that flexibility. So these numbers are, I believe, staggeringly higher than what we're seeing right now.
And isn't it, I think I remember reading somewhere that nurses, that workforce is the largest workforce in the healthcare profession. So just to say 1 out of 3, it kind of doesn't really help you to get a sense of how large that is. Do you know what I mean? Is that right? Did I read that right? Trying to remember where I heard that.
Yeah, no, for sure. If you look at healthcare organizations, at least 60% of the workforce are nurses. And if a third of the nurses leave the profession, we are not going to be in a very good place. Already now we're not in a great place in healthcare, and there's a lot of compounding factors that affect that. But for anybody who's had family members or ourselves had to go into the healthcare system as patients, you feel the stress of that shortened staff, that limited resources as well. So we're only seeing the tip of the iceberg, I believe, in this situation. I'm going to go to the next slide.
I'm going to speak briefly about Canada. I brought it up a little bit earlier. These are some March 2020, which was the start of the pandemic, but for Canada was, for most of the nurses that were surveyed in this, would have been sort of pre-pandemic phase, not quite hitting us yet. And so we don't have the survey that Romina, you described, where all nurses are surveyed in Canada, but there was one that was an attempt to do that in March 2020, and our numbers looked not great, but they weren't as high as the US and what you presented, Romina, prior to the pandemic. Now, if we go to the next slide, the next slide should be specific to our hospital. So where Tanya, Dr. Tajirian, and I work is a large hospital. She's going to talk a little bit about what it is a little bit later. We have done some surveys to get a sense of what the pre-pandemic and during the pandemic burnout rates are. And what I can tell you is that for both physicians and for nurses, we saw a stark increase. Not a surprise. What we're trying to disentangle is what we can actually do about it. And with our CCIO, CMIO hats, of course, we're going to try and tackle the technology pieces, but of course, we're not naive to think that that's going to address all of burnout. We know that this is a complicated problem. There's a lot of pieces to it. Some are sort of system level, some at our organizational level, and some things that we control at a more individual level. And so this is our fall 2020 survey results, showing that we were above the national average, although that was really a pre-pandemic average in terms of nursing burnout. And what we do know from the pandemic literature on burnout is that if you work in an ICU, if you work on a COVID specific unit, and if you work in the ED, those are the 3 areas that have been published in the literature to say that staff in those areas are suffering the most, not to say that staff in other areas, medical staff, are not suffering in other areas. The other groups that are shown in the literature to be particularly vulnerable are nurses, those who are new to professions, and those who are younger in age. So I will pass it along here.
So I think we've started talking about this as well. What are the healthcare impacts of the burnout? And this is kind of looking at the effects of burnout, of stress, and it's really crippling our ability for routine, preventive, and emergency care, let alone acute care. Right. So we've seen, according to the U.S. Bureau of Labor and Statistics, 3 million healthcare workers we have a shortage of 3 million healthcare workers, and 139 physician shortage that we'll see by 2033. That's a staggering number, again, and may not necessarily be all due to burnout, but certainly we're feeling and we're seeing an effect of that shortage of burnout for our clinicians. We've also been seeing in the U.S. some hospitals shutting down services due to staffing restrictions or staffing limitations, labor and delivery, emergency services, and urgent cares. Again, according to the Bureau of Labor and Statistics, we are requiring 1.1 million nurses in order to address the staffing issues that we're having. So if we're thinking that burnout is not an issue, and it's not an issue that needs to be addressed, we are disillusioned because it's affecting our staffing. It's not only affecting our clinicians, but it is going to be affecting and will be affecting patient care as well.
In this the study that this was taken from, the shortage for the physicians, is that based on maybe the assumption that there's no action taken to help reduce that? Like, this is the rate at which the shortage is continuing up until 2033?
Yeah, so it was done by the Association of American Medical Colleges, and that was their projection based on the needs of the services, all of the different services that we need and how the population is growing, based on a ratio of physician and then again, patients. So based on the growing number of population and the need for physicians and the number of staff going into that profession, they're foreseeing that this is the number of need that we will need, that we're not seeing, that we won't have.
Right. So now I'm going to go a little bit in more depth about how are we going to address the impacts. Was there sorry, Tanya, was there a comment you wanted to make?
No, I think I'm next.
Oh, okay. I'm going to go over there. There you go.
So I loved everything that everyone has said so far. So what can we do about this? I think all of us know that there's different models and frameworks for wellness. What I really like is the Stanford model of professional fulfillment. And this is not just about physicians, all clinicians, and also anyone that works anywhere, because we know burnout is a work-related syndrome. So this model kind of says, in order for you to have professional fulfillment at work, which will mitigate your burnout, the focus is, yes, what are the things that you do personally, your personal resilience? I always kind of say the self-care, the work-life balance, what fills your cup. It's always important. But this model kind of emphasizes it's not just about what you do, but the organization that you work at has to have a culture of wellness that resonates with you. What are the leadership values at your organization? What is the values? What are the, do you feel appreciated? Is there transparency? Is there inclusion? Basically, do you agree with everything, not everything, but the culture of your organization? And the other part is efficiencies of practice. What is your organization doing for a critical part that promotes wellness? This is staffing. Do you have enough staffing? Do you have enough admin support to reduce the things that you're not supposed to be wasting your time is? And the other thing, as we are in the digital framework here, usability of your EMRs. It's very critical to make sure that that's also addressed. In the center of this is your professional fulfillment. And I personally have been reflecting what are the things over the past couple of years that reduced my burnout. And I had to stop and think about it. And I was on a vacation and I thought, feeling respected and appreciated during this difficult time has been very, very important. Having connections, virtual or non-virtual, it kept us all going. Having flexibility at work in my role, having that ability to do hybrid, not only frontline, but I have leadership positions. So having those things really reduced my burnout and improved my professional fulfillment. So I think it's very critical everyone steps back and thinks about their own, because nobody has the same components of the pie. Next slide. So this is, as Jillian did great with talking about the nursing situation in Ontario and Canada. What about the physicians in Ontario? Not surprising, we don't have the high levels of the burnout that is estimated in the state. But as we can expect, 2020, the year of the pandemic, and the year after, there has been an increase of burnout. And we've been measuring it not with the MBI, but with the mini-Z. So the rates went up for full-on burnout from 29% to 35% in 2021. And the alarming part that 73% of our physicians are saying that there is some symptom of burnout that they're experiencing. So our Ontario Medical Association developed a task force last summer, and finally they came out with system level recommendations that organizations should think and prioritize. And I remember very distinctively, Jillian and I, when this came out, the report is calling Healing the Healers. It resonated with us because look at the digital impact. So the first one is, and I think it's equivalent as what we're hearing from the states, reduce the required documentation. In Canada, we don't even have the billing requirements that you have, and we still have major concerns and issues with useless documentation, I'm gonna call, and the admin work. Number 4, again, I think it resonates with every clinician. Seamless integration of any digital health tool, it has to be within the clinician workflow. Otherwise, you know what, uptake is going to be very poor. Number 2 and 3 resonates, I think, with all workers. Compensate me for the work, for all of the work I do, and increase the work-life balance by making policy changes at the organization. Like I said, this hybrid model, the flexibilities is all important. And finally, provide the organization level system support for all of your clinicians' wellness. But like I'm highlighting, and this is HIMSS, 1 and 4 was, again, digital tools. Next slide.
Oh, I was going to ask, how do they enforce, I guess that's a strong word, but how do you think, how do you have organizations adopt this, I guess?
So I'll tell you our story. So this is kind of nice. So the next couple of slides, I can talk at least what we're doing at CAMH.
Okay, sure.
So CAMH, the hospital that Jillian and I work at, we are the largest mental health and addiction academic hospital in Canada. We are University of Toronto affiliated hospital, world leaders in the brain science research, one huge campus with 14 satellites, and we have 90 distinctive services. And we're a HIMSS IMRAM stage 7 and the analytic stage maturity of 6. So sadly, again, I find sometimes a lot of us go through the path of wellness because of personal experiences. In 2017, 2 of my hospitalists died in tragic circumstances within 6 months. I always kind of say there is survivor's guilt, and we don't talk about it, especially as physicians, when you have loved ones die in tragic ways, but it's been a mission. And at that point, because of the tragedies, the hospital, the organization invested in developing a physician wellness committee. And the strength of that, and again, we've been going since 2017, it's led by frontline physicians, and we've created different buckets. We have a robust peer support program, and again, it's a tap-in program versus tap-out. We have a professionalism office, and again, during COVID, we're seeing that there's a lot of, again, angry behaviors that it could be based off nothing other than burnout. We have mentorship opportunities for all of our faculty. We developed communities of practice from the new grads to I'm going to say the ones who hopefully are going to be retiring. And again, it's that common themes that are meaningful for different parts of your career. We have a fantastic leadership training program that's called LAMP. And again, as a CMIO, I'm very much interested in wellness informatics. So the last bucket is mine, which is the efficiencies of practice. How do we reduce our EMR and technology related burden? So this is just going to show like what we're doing is engaging your frontline clinicians. I always kind of feel very strongly. We did a survey in 2019. Our burnout of our physicians was 25%, but 75% of our physicians and learners blamed our EHR as one of the top reasons of their burnout. So what we did after getting the data, collect the data, we invested into strategies where the center is the frontline user. So we develop EHR SWAT teams where we go and try to fix on an academic division level the problems. The initiative is we develop monthly think tanks, and again, bringing that IT voice with the frontline clinicians in the same room to troubleshoot problems. And at the end of the day, we all care about improving quality of care. Then developing dashboards, you're capable with data at the back end to see how you're using the EMR. So again, I think we all struggle in this area, which is the impact. How are you able to show that the interventions that you're investing in is actually providing the impact that you would like? So we have tremendous amount of data at the back end of our EHRs. How do you use it effectively in non-punitive ways? And finally, we've been very creative in how to develop our education, our communication strategies with very fun newsletters Jillian and I do, and developed, again, peer short videos, and with the same mantra of how do you engage different stakeholders? How do you inspire them to work together in order to sustain and provide ongoing change? So this is what I said, at least this is what we've been doing at CAMH, and Jillian has a wonderful strategy for the bigger group, as I say, not with 400 physicians, with 800 nurses at CAMH.
Thank you. So I think similarly, there was recognition from the U.S. Surgeon General about the need to address clinician burnout and stress. So the U.S. Surgeon General put out an advisory on how to address clinician burnout, and they did have several different suggestions. They spoke about what organizations can do, what the payers can do. So I wanted to focus on what organizations can do, and then what that translates to what technology companies can do. So one of the things that they had mentioned is transforming the workplace culture, and Dr. Tijerian had also spoken about this, right? It's not just addressing your personal level, and I think Jillian and Kira had also mentioned this, it's an organizational and a system level intervention. So transforming the whole workplace culture, and that means empowering your healthcare workers and being responsive to their voice and their concerns, and involving them in those, looking at how to improve processes to be able to address burnout. They also spoke about building a commitment to health and safety of healthcare workers. Unfortunately, with the pandemic, the rise of workplace violence had also been staggering. So we're seeing a lot more violence in the workplace. So building and making it a commitment for the safety of healthcare workers is a must to address burnout as well. Doing zero tolerance for violence for healthcare workers, for organizations, is a must. Building in those EAPs, or their employee assistance programs, and also Dr. Tijerian had mentioned it, measuring, assessing, and intervening. So how can we make sure that the interventions that we put in place are actually working if we don't measure it in the first place? So I think those are important things as well, and that's part of the building that commitment to health and safety. Increasing the access to high quality and confidential mental health and substance use care. Normalizing conversations about mental health issues and substance use for health workers, And there's still a bias and a stigma on mental health, particularly for healthcare workers. And I think we need to start talking about it more and normalizing that conversation, because we can't help each other if we don't talk about it. And if there's a stigma behind having issues and suffering from mental health issues, then we won't be able to actually address it. And lastly, and again, these are just examples of what the U.S. Surgeon General had put out, and we can put the link for their advisory as well, is prioritizing quality time with patients and colleagues. And one of them is building efficient workflows and technology. This has been mentioned before. That's one of the biggest stressors for our clinicians. But it's not only that, it's also investing in peer-led evidence-based practice for coaching and support for each other. Programs like the Complex programs that help. It's called the Community of Practices and Safety Support. So building in that peer group community to be able to talk about the stress and burnout for your colleagues. That's one of the things that have been recommended by the U.S. Surgeon General. So talking about efficient workflows and technology, they had also, and Joanna, if we switch to the next slide, please. These are what technology companies can do to help. First of all, making sure that the EHRs are accessible and easy to use and efficient. Taking away those double documentation, or actually implementing strategies that completely eliminate the need for documentation for processes that don't need clinicians, right? So making sure there's a lot of technologies like computer vision that automate that process, so that clinicians can actually focus on taking care of actual patients. Co-designing telemedicine and virtual care services and involving end users in that process as well. So I think we spoke about this already. Having end users involved in the whole process of designing and implementing would make these technology solutions even more effective for clinicians. Designing platforms with the goal of interoperability and really breaking down those silos of different technologies and different solutions that end up adding more work for clinicians to do. We have these disparate systems that solve one issue in healthcare, but then we add another system on top of that, and then another to solve yet another issue. How about we look at the whole system as a whole, look at a platform approach, so that we can make sure that everything is connected and there's an integration of the data across different platforms and sectors. So that's the other point here. And lastly, improving the seamless storage and access of healthcare data. There's no reason at this point that there should be incongruencies in how we access and how we store the data for healthcare. The data should follow the patient, really. And I know I'm talking from an idealistic point of view, but there's really no reason why the healthcare data for our patients are so incongruent that the patients end up having to, or the clinicians end up having to search for the data for our patients. So I think these are just a few of the examples of what technology companies can do to help, and the link for the actual advisory, we'll post that in the chat as well.
Thank you. So our next polling question is, does your organization have a program in place to help reduce workplace stress and increase well-being? I'll launch that. I'll stop this. And if you type yes, if you could put some details in the chat and I'll read a few of them. You guys are fast on that one. Got a lot of answers like in the first 10 seconds. All right, I'll send it for now. So yes, 78%, that's good. Let's see if anyone has put anything in the chat in terms of examples of programs. At least Jillian did. We do have a number of wellness resources, so employment assistance program, mental health resources, exercise classes. Washington Department of Health has mental health breaks, yep, built into the 40-hour week where you can pick something of interest to do on the clock. And Kara, I was wondering if you'd be able to comment on that the new 811 number that we
988.
that we
that
now
number.
have. Oh, 9 is it 988?
988, yeah.
Okay. Yeah, I don't even know the number.
Yeah. So 988 just took the place of regional and sometimes local suicide prevention hotlines. So it's a national 3-digit code that you can dial now and immediately be connected. There is a little bit of controversy around it because it is all national. They feed your physical location into a regional database so that if someone needs to be deployed to provide immediate life-saving services, they know physically where you are. So the issue there is that there is more sort of location tracking than a lot of people might feel comfortable with for a suicide-related hotline. So there are definite pros to it. There are some concerns that have come up in recent months. I know that they are trying to figure out how to work that out. With any huge national rollout, there's going to be things that they need to adjust and fix with it. But I know that that's one of those things. So that is something that, is sort of a standard now recommendation because it's the same number that can be used anywhere you are in the United States. And if you were to call it, you would be routed to support services in your geographic area. One of the issues too, can I just add something else, Joanna?
Yep.
One of the big issues with support resources is that, at least in Washington, one of the things we've been confronted with for a while during the pandemic is that there just are not enough professional providers, right? When it comes to behavioral health needs, you can sit on a wait list for several months. Washington was ranked 44th or 45th in the United States in terms of behavioral health resources for adults and youth before the pandemic even happened. So we are looking at an incredible dearth of providers. And one of my team members is organizing or has been working on a program called Stepped Care, which is a program designed to train graduate students in trauma-focused CBT and use referral sources through Children's Hospital and some of the school districts that are local that can provide a stopgap behavioral health support where they're trained to provide TFCBT for a certain number of sessions and to do an ongoing assessment to refer forward if that's needed, but hopefully to discharge the client at that point. Because, getting licensed folks to provide those services is really, really hard to do, if not impossible right now. In my private practice, we haven't had a single clinician with availability for most of 2022. Nobody has been able to take new folks. So that is another layer of this sort of overall response to the need in terms of mental health. Yeah.
Great, thank you. I know where I work, they have built into the AHR questions in regards to your mental health, and then depending on your response, you might get asked more questions. But it's interesting that you say, even though they show or they are flagged as a high risk in terms of mental health and they need the help, there's not enough services or providers to help address that. So that's interesting.
I can echo that as well. Yeah. So when I had done my doctorate, it was on the OB population, opioid use disorders. So we set up a screening tool for for opioid use disorder risks. But then what I've found is that, yes, we do screen them, we identify them, but there are not enough resources, unfortunately, to help them post-discharge or even during, during their prenatals. So it's so eye-opening to see that we recognize that there is a need to screen, there is a need to recognize and really help for our mental health, but then we don't have enough resources in our anywhere for them.
Yeah. All right.
Okay.
I think this one.
So
yes, there you go.
I'm, as was said, the founder and CEO of Maestro Games. And what we do is we build resilience technology for first responders. And so we use music, virtual reality, and we gamify it to bring players literally moments of beauty and joy and awe and delight as a way of countering PTSD, moral injury, burnout, and stress. We did a case study with the nurses at Children's Hospital Orange County. And it started before COVID and bled into COVID. And so a lot of the data that you'll see on this chart came from the COVID experience that the nurses at CHOC were going through. Basically what they did was we had a demo that we built. Was 3 minutes and 40 seconds. All of our experiences are between 3 and 6 minutes long because we know that first responders, especially healthcare providers, don't have time to go to the bathroom, much less spend, an hour in a yoga class or an hour in a VR headset. So we made everything very, very quick and very powerful. So we used the piece of music called Morning Mood from Peer Gynt by Edvard Grieg. It's a very uplifting piece of music with a wonderful emotional crescendo towards the beginning. And we paired it with a sunrise that happened. So in the experience, think conducting the orchestra. So you have a conducting baton in front of you that you pick up in this VR experience, and the conducting baton kind of has the Harry Potter treatment to it, and it has stars and streamers and a smoke guide trail. And the guide trail changes color, goes from red to yellow to green if you are in time with the music, which is one of the goals. And then we put in some other gamification aspects of this, just so but very light gamification. We wanted to see what would happen and if people would relax. So as you can see from this poster that CHOC did, and there was an article that was published in the Journal of Nursing Administration from this case study that Jennifer Hayakawa and Susan C. and Jennifer Burrows and John Schomburg all wrote that talk about the case study. They wanted to see what would happen with PTSD, but also burnout. And what they found, as you can see in the chart on the third column, is that in the red, it was before they did the Maestro intervention, and in the turquoise, it was after the Maestro intervention in terms of how they rated their quality of life, their burnout, and their stress. What was interesting was the nurses in the NICU unit were the youngest ones and also the ones that were most impacted by PTSD. And they were the ones that benefited the most from doing the Maestro intervention. What was also interesting was they didn't do it very much. They did it, 3-4 times over the course of, I believe it was a couple months. One of the things that's really, really interesting about what Maestro does is that the more you do it, the greater your benefits are. So you're creating new neural pathways because you're gesturing, but you're also secreting dopamine, serotonin, and endorphins. So we're very proud of this case study, actually, because frankly, as I did not expect the level of results like this just from the demo that we built. It's now a commercial product, and the nurses at Children's are doing another case study on the mental health of their mental health professionals, and I'm really excited for that one because that one's going to focus more on moral injury And so we're going to be, and obviously that's going to be far more COVID related than this one was. So I'm going to be very, very excited to see that. We also have a research agreement with Kent State in Ohio. They are researching how Maestro affects the stress that causes aggression and violent behavior. So I mean, that one's going to be very important for, obviously, violence in healthcare and violence in the workplace. So we're very excited that to get validated this way, because at the end of the day, music is the most powerful ancient technology known to humanity, to not only light up parts of the brain, but also, frankly, light up the heart, light up the soul. And so we're very excited that we found this wonderful way to help providers process the emotions. We're not mindfulness. I want to make that very, very clear. We're not mindfulness. We're a safe space to start processing your emotions. If you'll permit me a quick story with a swear word in it. I'm part of an organization called Mindful MD, and we had a retreat in the beginning of June, and the healthcare providers that were there were physicians, and they were all just massively burnt out from all over the country. And there were about 20 of them there, and I was on a panel talking about the importance of beauty and healing. And in my remarks, I said, I fully expect that someone's going to pull the headset off, throw it against the wall, and say, fuck you. What makes you think that this stupid little toy is going to make me feel better? Don't you know I've been pulling bodies for 2 years? How dare you think that this toy is going to make a difference? And so I'm like, okay, fine, bring it on. And so because one of the women in the audience is a refugee medicine doctor, but she had just come back from Ukraine, but she also is urgent care in Brooklyn, and her level of trauma and moral injury and burnout was just absolutely off the charts. And so she raised her hand when I said that comment, and she said, yeah, that's going to be me. I'm going to break your headset. And I'm like, okay, fine, bring it on. I mean, that's why we're here, And so after the panel was over, she came up to me and she said, so can I break your headset now? And I said, sure. So she put it on and she did the Peer Gynt morning mood experience. And again, it's 3 minutes and 40 seconds. And, took the headset off when she was finished and looked at me, and she couldn't speak, literally, couldn't speak. And she just burst into tears. And she said to me, I would never believe that anything would enable me to unlock the shit that I've stuck down. And I think that is the key to healing. There has to be not just us, obviously, but there's got to be a safe space to even begin to dismantle what we've put in our bodies and what we have calcified in our nervous system in terms of the trauma. There has to be a way to just start breaking that wall just a little bit, chip by chip. And that's, I think, we're very honored to be one of the things that can do that.
And I have to echo that. And Yael and I work together, obviously in a technology company, and this is really one of the things why I got into healthcare IT. Is I know and I truly believe that being healthcare and IT so integrated together, technology does not have to be a burden or a kind of a crutch even to providing healthcare. There are good technology implemented correctly can really truly assist our healthcare, our clinicians, our patients, and make even that experience for both clinicians and patients so much better. So VR, AR, ML, they're growing in the use cases and what we see in technology. And I think this is just this is an evidence-based project that proves that it can work. And then again, technology done right, because we've seen technology done and implemented wrong and had caused some burnout for our clinicians. I think there's a lot of work to be done, but I also think if we reframe our mindset and look at technology and partner with technology companies to really design it for clinicians. And with that in mind, I think we can truly make a difference.
And one of the things too, I mean, the whole electronic medical record issue, I would love to see, frankly, if clinicians did Maestro for 5 minutes after plowing through the electronic medical records, it would go a long way to a line of demarcation, if you will, of, oh, I just finished that massive task and I'm so burnt out. Let me recharge my nervous system right now. Let me go do this, and then I can go about my day or sleep or whatever it is. Because so many physicians, are doing their EMRs at late, and then it's in their mind, and they're thinking, what did I miss, or what didn't I write, and all the other things that they need to do. There has to be also a way that they can say, okay, I have finished that. Let me do something to recharge myself now that's completely away from that, because that's also part of, and also addressing telemedicine. Right now, the recommendation in telemedicine is that in between patients, that the provider watches a cat video on YouTube as a way of detoxing from the patient they just, maybe had to give bad news to, right? If you're in oncology. And I'm like, first of all, I'm a dog person, so full disclosure. But it's like, seriously, you're watching a cat video. How is that supposed to recharge you? I mean, yeah, it does give you some oxytocin and things, but I think we're grasping for things, and there's far better ways, not just us, but there are far better ways to recharge other than trying to do a cat video or playing around on Facebook in between your patients.
Great, thank you. Those are just the references. So I'm gonna go back. So we have a few minutes left. We end at 5:30. And this slide is basically asking us what actions for ourselves can we take now. And I think I'm gonna flip forward. After that, we'll have our Q&A. So if we could spend maybe 1 or 2 minutes on this slide, and we'll take questions from our audience members. Any of the panelists want to make a comment on allyship, increased awareness, or a call to action?
I would want to add here that one of the most concrete, individualized, and I'm coming from that clinical psychology lens again, but like an individualized strategy that we know is fairly effective is to create a personal coping plan. The data is really clear that knowing, sort of anticipating what you're going to be exposed to based on what you've already been exposed to, and then writing down things that you can do in different time periods, things that you can do at work with the door closed, on a 5-minute break, things you can do in the evenings, things that you can do on the weekends, etc. And then stick it on your refrigerator, have it on your phone, like make an accessible coping plan that has healthy coping options, right? That if you don't create the plan and then work the plan, it decreases just the likelihood of healthy coping versus avoiding, dissociating by just being on TikTok for 4 hours, all those things. So yeah, the active coping plan that you can just put on one page, keep it simple, keep it those SMART goals, the same kinds of things that we've heard about for years. It has to be manageable, achievable, time frame specific. And also identify like how when you need to use it, right? A list of like what are the warning signs? Are you getting aggressive? Are you getting really irritable and short tempered, that kind of thing. So a personal coping plan is a big recommendation.
Comments?
I think, Eric, you have your hand up.
Yeah, so this is a question for Romina. You're basically saying that vendors need to get their act together. What has been your experience with vendors so far?
So very varied experience with vendors. And again, I started in at Dell not last November. So I have seen some some vendors as well. What I've found is that some vendors who do not have clinicians on their team have a very different view of solutions. And I may be biased because I'm a clinician in IT, but I think we bring, as clinicians, as informaticists, we bring a different perspective in solutions. So I think that's my view. Not to say that there are no vendors that have a great program and a great solution out there. I have seen some that's completely missed the wall on that because they don't have that clinician perspective.
So taking this, to put on my vendor hat, I worked at GE Healthcare for 10 years. When a product gets sent out to the hospital, they have to conform it to their policy. Mm-hmm. So there's a lot of times where vendors have good intentions. Vendors don't know a lot. I mean, they've got a good product, but it's basic. And so it's really something that is promoted by the organization. And so there is some vendor involvement, but there's also training. I saw that where, for example, Swedish First Hill, we had doctors that were ready to jump ship on the Epic product, and they simply weren't trained in how to do the right type of documentation. This was a GI clinic, and they just took the standard build instead of the GI build, and so there was a lack of training. There's also the enterprise architecture. They're a hospital's enterprise architecture will defeat a lot of the advantages that the EHR is doing, because they have multiple systems going. They'll have bandwidth issues. We were doing Blaze products where we're doing clinical support way back in 2000, and it was hammering the system, so they just shut it up. So enterprise architecture turned it off. There's this idea of usability, and it kind of gets lost because it really takes someone who understands process mapping. I mean, I've seen it where it's not double documentation in the same EHR, but in one case for one person getting surgery is documented in 5 different EHRs. And so there's all this documenting that goes on because the technology isn't necessarily hooked up in the enterprise architecture.
Correct.
And then finally, the policy. When you talk about double documentation, you do something like a clinical note builder, the policy says you have to have a progress note. Now you have an unstructured document and a structured document. They're the same document, but now you've double documented. So it takes usability, it takes process improvement, it takes clinician input. The vendor definitely has a seat at the table, and it also takes usability. So I would say that there's kind of a myriad of things. I don't know if the vendor's smart enough to give you what you want.
No, and Eric, I appreciate that comment. I 100% agree. And it's not just the vendor, right? And it's not, sometimes, most of the times, it's not the product. It's how you roll the product out. One is making sure that you have your enterprise architecture all built in and set up. And 2, that you have a support model to be able to support that transition. And believe me, and for those who have known me prior to, coming on here, I've always been, because I've been involved in a lot of implementations. I supported in Meditech, built in Meditech. I supported and built in Epic as well. So I did that whole transition. The EHR is not going to teach nurses or providers how to do their job, how to be clinicians. It's just not. We are clinicians ourselves. We have to know how to do that. But in the same token, we have to design the system so it works for how we do our workflow. So I think that's where the implementation kind of makes a big difference. How you think of rolling out a solution into a hospital, the policies, like you had mentioned, that support that as well. And it's really the support model after that too. So I'm not, please don't get me wrong. I am not, you know, downing on the vendors. I do love my vendors and my partners and solutions as well. I am part of the vendor too, right? Because we're Dell, we provide that solution, the infrastructure. And this is why I think the investment in technology needs to really happen, because it's not just the money or the resources, but it's also the time. Invest appropriately so that you can design the system the way it's meant to be, to put in a solution, solve a problem, and make sure that all of the different factors are actually accounted for, and not just put in a solution and then walk away, and then think that it's going to solve your quality or your faults or your reimbursement issue. It's not. It's a long-term process. And I also think that, and sorry if I'm in my soapbox, one of the things is technology solutions is not a technology project. It's a clinical project that has to have clinical leadership and IT leadership together, working together. I've found it and I've seen it a lot of times where there's a great clinical solution that's being rolled out and IT is being left too late in the table and then brought on late. So then they don't think of the enterprise architecture that needs to be put in place, or the support model that needs to be put in place earlier on in the process. So I'm going to get off my soapbox now.
Great comments. Anyone else have other questions? In the meantime, I've also posted a QR code and also put the link to a feedback survey you can all fill out. I don't see other questions that are in the chat. And so I'll go in. I just wanted to let you all know we do have more events coming up. You can find these all on our chapter website. We have an in-person one coming up. I have here mid-October, but it's looking like the beginning of November. It'll be a full day healthcare summit. So we'll have various speakers come with vendors. There'll be food and, you know, your typical conference style type of event. So that's coming up. And also I just wanted to put this up here. We had our first in-person event in the past 2 years last week, and it was a great turnout. And so I just wanted to put this here in case you were interested in joining, volunteering, or even becoming a sponsor. This also kind of gives you an idea of the various ways you can connect with our chapter, or if you wanted to attend some of our events, like I was saying earlier, or if you wanted to contact us directly. So we have 1 minute left, but on behalf of the chapter, I really wanted to say thank you to our panelists, Tanya, Romina, Yael, Jillian, Kira, Eric, and Lena for pitching in and giving us your comments on the chat, and everyone else who attended. Thank you so much. This is a great topic. I hope we have more on this particular one because it's so important. This is again being recorded, so we will post the link and send the link out in our upcoming newsletter as well as our website. So thank you again. Take care. Be safe.
Have a great evening,
Bye.
everyone.
Thank
Bye.
you, everybody.
Thank you, everybody. Thank you.
Thanks.
Thank you.
Bye-bye.